Good evening, everyone. I'm your only Dr. Fache, obstetrician, gynecologist, and a fertility specialist. Today we will be discussing endometriosis and fertility. I would implore those of you who have joined, thank you for joining, to use the question tab, the button, to ask your questions. So that at the end of the program, we will take the questions and address them one by one. I hope you can hear me. So if you also know, I also like comments on, for those of you who understand what endometriosis is, just so we know how many people understand what endometriosis is. So you can just put that down in the comment section as well. So I would start by defining what endometriosis is. Endometriosis takes its name from the lining of the womb, which is called the endometrium. The lining of the womb is called endometrium, and so when you have tissues very similar and almost same with this endometrium that is supposed to line the womb, outside of the womb, most frequently in the pelvic cavity, then we call it endometriosis. It's a benign condition, but a chronic one that is very debilitating, is distressing to those who suffer from it, and it can cause a lot of reduction in their quality of life. Now, let us look quickly. The lining of the womb is a special kind of cell that is constantly regenerating and shedding. So in the beginning of a woman's cycle, these linings begin to grow, and then at the end, when there is no pregnancy, the lining sheds as menstruation. Imagine that you have this same lining somewhere else in your pelvis or in the body, and then it's constantly undergoing this regeneration and bleeding. Unfortunately, because most of the places it is enclosed, they cannot shed. So it's either it's bleeding into the peritoneal cavity or it's bleeding into the ovaries. And it causes a lot of scarring. Eventually, it's a chronic condition. Like I said, the frequency is said to be about 10 to 15% of women in the reproductive age group globally. 10 to 15% would amount to like 190 million women in the reproductive age group. So at least that gives you an idea of how common this condition is. And one of the things that has become very clear is the fact that there is very minimal awareness about endometriosis. And this again has affected the sufferers of this condition. And so that is why the month of March has been set aside as the Endometriosis Awareness Month by the World Health Organization, so that everybody all over the world, we use this month to educate people, both healthcare practitioners and the general public, about endometriosis and its consequences and effects on their sufferers. So that's 10 to 15% of the general population. But in people who have infertility, it affects 25 to 50% of people who are suffering from infertility. And that is one of the association. Imagine that, okay, maybe 1 in 10 people generally, but if you gather the population of infertile women, about 25 to 50% of them would have endometriosis. That is how common this condition is. Now the question is, why, if it's so common, why are we not aware of this? Why are so many people not aware? Even the people who are suffering from it, why are they not aware? So the cause is unknown. that's one of the challenge. We do not particularly know the cause, and so we also do not know predisposing factors. We know that there is familial correlation, like if somebody has a mother, sister that has first degree relative, for instance, that have endometriosis, female, then you have a 7%, a 7 times higher chance of developing endometriosis compared to somebody who does not have a relation that has the endometriosis. So we do not know the cause, like I said earlier, but there are some theories that have been propounded long ago. First among them was propounded in 1920 by a gentleman called Sampson. And what he taught is, when you look at this model, I hope you all can see it. This is the female pelvic model showing the vagina here and the cervix, then the womb itself, the uterus. So the upper part has been cut off. Sorry, it's supposed to be enclosed like this normally. This is how it is, So this part has been taken off so that at least we can understand some of these conditions. And so the pink lining inside the womb is the endometrium, which is the lining that Shell have been talking about. And all these black dots you're seeing around it signifies endometriosis. You can see them. You can see this one inside the muzzle of the womb. You can see this outside the womb. You can see endometriosis in the tube. On the tube. You can see them on the ovary. You can see them on the vagina. You can see them on the back. This is usually the back of the uterus. And so everywhere you've seen them, you can see it in the vagina here, inside here. So imagine that every month this is creating inflammation. So the theory says that when a woman is menstruating, normally the menstruum, that's the menstrual blood, comes down through the cervix and is discharged through the vagina. But the concept of that theory says in women, especially, of course, those who have whose tubes are open, there's what we call retrograde menstruation, where instead of the whole menstruum coming down through the vagina, some of them are going through the tubes, and they are discharging into the peritoneal cavity. And so that will explain why these lesions are finding themselves, on the structures around the pelvis, because they have been able to travel through the tube and then discharge into the peritoneal cavity. So that is the theory of retrograde menstruation. This theory explains the majority. It makes a lot of sense in women who have endometriosis, because again, I forgot to mention that it's a disease of the reproductive age group, meaning that it's not seen in women who are yet to see to start menstruation, which is menarche, and then the lesions tend to regress after menopause, when of course the woman has also gone out of the reproductive age. So it is something that happens during the reproductive age, and it is thought to be dependent on estrogen, which is the dominant female hormone. So the question is, okay, so the other theories are saying that, okay, it is possible that the peritoneum, the peritoneal cells can undergo what we call metaplasia. Metaplasia is saying that instead of the cells being of a different form, they can change form and come to look like the lining of this endometrium and behave in a similar manner. So this, is a disease of theories. So, but as it is today, we are not sure of the actual cause, and because none of these theories can explain fully all the manifestation of endometriosis. But put together, yes, they can all, maybe 98% explain one theory, one manifestation or the other. So that is about the cause. Now coming to symptoms. The symptom of endometriosis, which is one of the reasons why there's so much, so little awareness about it, is the cardinal symptom is pain, menstrual pain. And as you may all know, menstrual pain is something that is thought to be common. Yes, There are instances where dysmenorrhea, as we call it, occurs just as part of the normal menstrual period, especially in women who are ovulating. And so people, thought that, okay, the one that comes with endometriosis is just a severe form. So considering the stigma and some taboo about menses is something that is hidden, you can stay with a woman for 10 years and you cannot tell when she's menstruating because they know how to keep it like secret. So when they're having this pain, they also try to cope with it. Most of people, when the pain becomes excruciating, they are being told as if they are not able to manage womanhood properly. They are not supposed to be complaining. They are not even, sometimes they are not allowed to take painkillers. Okay, just leave it out. This is not just about the general public. Even some of us health practitioners dismiss the pain that women who have endometriosis are suffering. And as it continues, like I said, it's a progressive, it gets worse. It's not a condition that truly, if you leave it alone, it will just regress on its own. So as it is progressing, the pain is progressing. And so you would see that maybe in the beginning, you're able to take paracetamol to relieve the pain, and gradually, you are increasing the dose of the paracetamol. You're having to change to another painkiller, just to be able to manage the pain. Then gradually, it gets to a point where you're having to go to hospital in search of stronger painkillers. It is, it's such that some of these women have become drug addicts because they have become dependent on taking this strong painkiller, some of them that have addicting tendencies. So, and then you can also look at instances where some of these women, imagine that every month that a woman is menstruating, she needs to go and be admitted in the hospital, maybe for 3, 4, 5 days, depending on how long her menstruation lasts. She needs to go and be admitted in the hospital to receive painkillers, to receive drip, because it also comes with nausea and vomiting. It can be quite debilitating. Over time, because of the scarring, I have shown you the model. All these places that you're seeing endometriosis, all of them, there is scarring. So it's like the woman's pelvis is on fire during her menstrual period, because like you have a wound that just is not healing. It just subsides during part of the month and then becomes new again. So the same way the womb is behaving, that is how those tissues are behaving anywhere they are. So over time, they cause significant scarring. So this cyclical pain over time becomes persistent pain. So it's no longer cycle dependent, and that is because of the enormous scarring and inflammation adhesion that it's causing. So you begin to feel like, okay, even when I'm not seeing my period, there is chronic pelvic pain. That is another cardinal feature. So from cyclical pain to chronic pelvic pain. Now, and then you can imagine the other symptoms. They are quite straightforward. If you have endometriosis in the vagina here, it means that during penetrative intercourse, you're going to be having pain, what we call dyspareunia. Again, because of the adhesion. Well, what we mean by adhesion is that other structures like the intestine, the ovaries, everything, the tubes are affected, are gummed together. And so when there is intercourse, anything that puts pressure in on the uterus causes significant pain. And so when we get to discuss how endometriosis is related to infertility, you would understand. Because if you are not having intercourse regularly, because anytime your husband is coming, you're thinking of the significant pain, or maybe after intercourse, they have to take you to hospital. So imagine how that can affect even peace matrimonial homes, And then, of course, imagine that you are working and then you tell your office that every month I'm going to be taking 3-4 days off work because I need to go to the hospital. I'm sure one of those days, by the time you're coming back, they will have written sack letter. And then, so this, it's a very serious, disease. And so these are some of the symptoms. Of course, mass in the pelvis, and especially in those who have ovarian cysts, what we call endometrioma, because like you see in this model, when you have this endometriosis in the ovaries, then it can begin to bleed inside the ovary and form cysts. These cysts, of course, because it's blood that is going into them, eventually when we see them during surgery, their content is like thick chocolate. So we describe them as chocolate cysts, but the medical terminology is endometriomas, which are ovarian cysts arising as a result of endometriosis. It is also such that when you find this endometriosis, like this one in the muzzle of the womb, it gives rise eventually to what we call adenomyosis. So, that has given a rise to the name. People call this endometriosis interna, because when you have endometriosis in the wall of the uterus, it's still like, okay, it's part of the house now. So, it's like it's still in the uterus. But so it causes so endometriosis in the wall of the uterus is described as adenomyosis, which is another very, worrisome condition to have. And so the ones that are outside are called endometriosis externa, just for the purpose of describing which one is inside the womb. But of course, the lining of the womb is there, so that one is the natural abode of the endometrium. So, that's not a problem. So, those are majorly the symptoms. You can have heavy menstrual bleeding. You can have, of course, painful menstruation, difficult, difficult intercourse like dyspareunia. You can have, some people have problems with defecation. Every time they go to toilet, they have a lot of pain. And that is because their intestine, especially the rectum, have become scarred. The large bowel have scar on it. And so sometimes it may even come with bleeding around the period when these lesions are also shedding the same way that the lining of the womb is shedding. So sometimes people have bladder endometriosis, and then they have blood in their urine. So that's what we call hematuria. So these are all the symptoms. So these symptoms, as you can see, are symptoms that can be caused by so many other conditions, and that is why the diagnosis is usually very difficult. And so, coming to diagnosis, now, how do we diagnose endometriosis? First and foremost, it's important to note that the diagnosis is very challenging. One, it's been estimated that it takes an average of 8 years from development of symptom to getting a correct diagnosis, having gone through so many medical consultations. Globally, that is the average time, 8 years. 8 years, imagine a baby that is 8 years. In these days, maybe she's already finishing primary school. And so that is the length of time that it takes for a woman who have endometriosis to get a correct diagnosis. And of course, if we're saying globally, it means that this is even the average in communities that are considered high-tech, like America, the UK, Japan. So if you bring it down home, then it's possible that some people may never even get a correct diagnosis in their lifetime. That is how bad this is. So diagnosis, symptoms, and like I have said earlier, if I'm having menstrual pain, then I may assume that is normal. So first, I may not even be able to discuss it, and then I discuss it with my mom, and she says, oh, it's normal for people to have menstrual pain, just be strong. It's not. So there is a delay on the side of the patient in seeking medical help. That is one. It is said that it's estimated that it takes an average of 3 years even before patients who are suffering, from this condition, because usually, yes, it starts as a mild condition and is progressive. So it takes an average of 3 years for them to even seek medical help. Then by the time they seek medical help, it takes another average of 4 or 5 years before a right diagnosis, because usually this medical help in our environment starts from the woman going to the chemist first, then to herbalist. A lot of people are doctors these days, and they're advertising their products online. So then they go to pharmacists, then they go to primary care physicians as general practitioners, who may also be reluctant initially to say, okay, I think this may be something just beyond ordinary menstrual pain. And so all these delays eventually contribute to a destruction. So as gynecologists, the majority of the patients that we see present to us with infertility. And at the time they are coming, most of them, their condition is already advanced. Their tubes are damaged, because when you have endometriosis lesion on the tube and it's causing scarring, the tube will be damaged. The ovary is damaged. Some of them have had surgery for ovarian cysts, where a large chunk of their ovaries have been taken out. So, I'm digressing into how endometriosis is related to infertility. So, this diagnosis, prior to this time up until now, is usually dependent on having a surgical diagnosis, which is having a laparoscopy. Laparoscopy is a minimally invasive procedure where you can gain access into a woman's or anybody's abdomen with a small buttonhole incision. Imagine the buttons, the regular buttons on your clothes. That incision, that size of incision is what you need to put in a laparoscope and be able to look around a woman's abdomen, including her pelvis. And so that is what is used to, the gold standard, as it is said, to diagnosing endometriosis, where we hope to see this endometriosis. And so recently, with greater awareness and advances in technology, we are trying to shift the paradigm. So it's okay, why do somebody need to undergo surgery to make a diagnosis? So we are creating awareness, alerting people, practitioners, to be more alert to this condition and be quick to refer. When you're seeing this symptom, first of all, the people should be quick to seek medical help. Then when you seek medical help, the doctor should be quick to refer to specialists who can, work out, put this diagnosis together. These symptoms together, and be able to say, no, this is beyond the regular just menstrual cramps, and so begin to initiate modalities of treatment. Because if this is not done, by the time these women are coming, so much damage has been done. So that is it for the diagnosis. It's a very challenging condition. So we are now relying on ultrasound scan, high resolution ultrasound scan, emphasis on going to gynecologists with special interest in endometriosis, because this is not branching to a roadside, no matter how big the names are. The people who are doing scanning in these places are usually radiographers. They are not, most of what we are discussing here is advanced. Short of saying that it's not even every gynecologist that has such in-depth knowledge about endometriosis. So we're talking about gynecologists with special interest in endometriosis. That is what we call subspecialization, or the Indians would call it super specialization. Like, you have devoted significant part of your time and practice to helping people with endometriosis. They can do this ultrasound scan, pick certain features, and be able to say with reasonable certainty that yes, you have endometriosis. And then, of course, this can be combined with what we call MRI, magnetic resonance imaging modality, together, so it avoids having to do the invasive laparoscopy to make a diagnosis. Short of saying that there are not too many people who can also do laparoscopy. And when people say they can do laparoscopy, there is a saying that the eye does not see what the mind does not know. Sometimes they see these endometriotic lesions and they miss it because they just don't know it. So it is not enough. People come and say, okay, we've done laparoscopy and they said everything is clear and they are happy. I don't think we should be happy when we have a condition that is missed by somebody who does not have the knowledge. You are having pain, you have all the symptoms, it's quite classical, and then you are happy that somebody had done ultrasound and say you're fine. But why am I having the pain? You know, we see this a lot. Infertility. Tubes are blocked. There are fibroids, and somebody tells you, oh, the fibroid is small, it's not a problem. And you're not asking the person, if it's not a problem, why am I not getting pregnant? We know that. So sometimes I think people should invest in trying to start their journey, whatever condition you find you have, with the right specialty. That is very important, so that in the end, cost-benefit analysis, you are not doing penny-wise, pound foolish. So that is the aspect of diagnosis. Does endometriosis cause infertility? When you read the literature, they are not very affirmative in saying yes, but like from the frequency, we know that there is an association between infertility and endometriosis. And from what we have described, what we have seen, when the tubes are damaged, when the ovaries have cysts, when you cannot have intercourse regularly because every time you have intercourse it's like you have gone to heaven and back, then it can affect, fertility. It causes chronic inflammation around the pelvis. So even implantation, even when there is fertilization, it can cause blocked tubes because of the scarring. It can cause, if you have surgery, even when there is no surgery, having an endometriotic cyst can affect the way that the ovaries function and the release of egg. Having endometriosis on the tube can affect tubal function, even in terms of ovum pickup. When the eggs are released from the ovary, there is a special mechanism through which the tube can capture this egg. That is affected. That's what we call ovum pickup. That is affected. Even the transportation through the tube is affected because the tube could be blocked, or there's just some form of a gallop on the way. And then when you get inside the uterus proper now, because of the inflammation that is ongoing, then implantation becomes difficult. So most of them are having what we call preclinical abortion, even when they get a preclinical miscarriage when they get pregnant. So it is certain that there is some relationship with endometriosis and fertility. So now we come to treatment. I'll start by saying, let me just go to the point of prevention, that because we do not know exactly the cause of this endometriosis, there is no logical preventive mechanism. Maybe if we were to think of prevention, we'll have been to say, okay, before the woman starts menstruating, can we just go and remove her ovary so that she does not make? But then you're just causing more damage than more harm than good. So for any woman that attains menarche, there is a possibility of developing endometriosis. And so early diagnosis and treatment is key. Now, when you come to the treatment, again, if you've gone through all these difficulties, okay, you finally get a diagnosis. This is a tissue that is similar to the lining of the womb. And we have said that it is like estrogen dependent. Estrogen is the hormone that goes around the women, that makes their skin succulent, help coordinate their menstrual cycle, the release of eggs, and the rest of them. So what do we do? We have categorized the endometriosis into 4 categories, stage 1 to 4. Stage 1 and 2 are usually considered mild diseases. And so sometimes you might just know, okay, there is this, but it's not going to cause you infertility immediately. So we are not saying that everybody who have endometriosis will have problem with fertility. That's not what we are saying. But there are more people who have endometriosis have infertility compared to the general population. We need to make that distinction. So there is what we call expectant management, where you've gone to see a doctor, you're just married, and you feel like, okay, I have endometriosis, and then the doctor is saying, we've done this evaluation, and then we feel that your condition is mild, or maybe you've had other reasons for laparoscopy and they've seen that you just have superficial endometriosis, and so you get this reassurance to say, okay, you don't need to do anything at this point in time. That is one, but it's not usually a favored type of management, because we have said that it's a progressive condition, so why wait? And so you may want to start. Of course, you need to improve your quality of life, so painkillers come to the rescue to help alleviate the pain when you're having them. Then other ways is to use drugs that suppresses estrogen or interrupts ovulation. And this is where the oral contraceptive pills have found usefulness as one of the commonest medication that is used in the management of endometriosis. But of course, we understand that people have aversion to this medication because once they hear that it's contraceptive, they do not understand that these drugs have found so many other uses in gynecology. All they are looking at is, oh, doctor, I'm looking for children, so why do you want to give me this? And that is where, again, as we go in the conversation, you realize that the management of endometriosis is actually very difficult, because you would realize along the line that apart from the routine painkillers, most other medications that are useful in the management of endometriosis would not allow the woman to get pregnant, because most of them achieve their action by suppressing ovarian activity, by suppressing ovarian hormone. And so that is where it's really difficult. Somebody wants to get pregnant, she has endometriosis, and so you want to put her on family planning pill. For how long is she going to be on it? And it's not like this drug is going to cure the condition. So it's not something you're going to give like, take this for 3 months, 6 months, 1 year, your endometriosis will go away, and then you would be able to just get pregnant. So it creates a very difficult situation, making that decision of what medication should I use and how long should I use it. So oral contraceptive pills, progestogen medication, then of course the higher ones like what we call the GnRH analogs, both the agonists and antagonists have found usefulness. Mirena, which is one of the intrauterine system that has hormone impregnated in it, have also found usefulness in suppressing this condition. And so it is useful. If you are not married and you are not actively trying to conceive, you have endometriosis, please take advantage of this medication so that by the time you are ready, because they would help you suppress the condition and slow down the progression. So all this destruction we're talking about, causing scarring in the tube and causing ovarian cyst, will be minimized when you take advantage of this medication. There are newer drugs now. The GnRH antagonists are coming. They have tablets. So the agonists are injectable, the injection, but we are now having tablets in form of antagonist tablets that can also help in alleviating the symptoms of endometriosis. When you are married and you're trying to conceive, then you need to have proper conversation with your fertility specialist, endometriosis specialist, so that you can both have a common ground on how you want to proceed in the journey. So the emphasis on this is also people marry and they want to do their honeymoon for 5 years. They're still doing honeymoon. So if you know that you have endometriosis and after 5 years your tubes have been damaged by this condition, then you may also want to make a decision to say, okay, you want to hit the ground running. And one of the things we've seen is that most of these conditions that are estrogen dependent, when the woman is pregnant, it also tends to slow down the rate of progression of this condition. So it may help you make a diagnosis as, okay, I would have loved to do honeymoon 5 years, go to Hawaii, London, UK, one year, times 5, the husband pays the money, no problem. So that, okay, I'm just going to do it for 3 months or even 1 month and try to conceive. So that is, when it comes to endometriosis and fertility. So I've talked about the medical from expectant, which is like, do nothing, just know that, okay, you have endometriosis, take painkiller because it's mild, to using medical, that's drugs now and injectables. And then sometimes surgery becomes the mainstay. This surgery, when it is important, is able to make a proper diagnosis now because you're able to see your condition. Now we are encouraging people not just to have surgery for the purpose of diagnosis. It should be for the purpose of what we call see and treat. You are having surgery because you have an ovarian cyst. And when you are having this surgery, it should be the one that is minimally invasive. That is our first choice. Minimally invasive, you are going in through buttonhole incision, but ironically, it sees better than the one that you give large shot, maybe from Cape to Cairo, the kind of up and down incision, even the bikini line incision. So look for specialists that can do laparoscopy, have your ovarian cyst removed with the surgeon, the gynecologist at the back of his mind will know that, okay, I don't need to take a whole chunk out of this woman's ovary because I'm going to be reducing her ovarian reserve. So removing cyst is not like harvesting yam or bringing down mango. So don't just go to any doctor who says I can do ovarian cyst, because invariably when that surgery is done, if utmost care is not taken, you are reducing your ovarian reserve, which is also one of the aspects that endometriosis impacts on fertility. When it causes you cyst, then you go to remove the cyst, then the cyst takes part of your ovary with it, and so your ovarian reserve is less. From our previous discussion, we have said that the eggs that women will ever need in this life, they have it right from their mother's womb. So if you take part of the ovary, you are taking away part of their ovarian reserve. It's very important. So when you're going to remove cyst, sometimes people go and say, okay, cyst is very big, and then what is left is almost like everything is taken out. So it's important to look for a specialist that have this at the back of their mind that, okay, reason for us, we're doing this surgery, we're removing this cyst, we want this woman to still have very significant ovarian reserve and be able to conceive. So laparoscopy gives you that opportunity, and you are seeing things under vision is being recorded, the vision is enlarged. So isn't it ironic that, okay, you're going through a hole, but you are seeing better than when the whole place is cut open. There's also a bit of magnification from laparoscopy. So your best choice of surgery is laparoscopic surgery, whether it's for the purpose of diagnosis or for treatment. It is laparoscopy. So look for those who have the skills, look for hospitals where these are being done, word of mouth, for you to be able to know that truly, don't believe so much in people who are singing their praises. Ask people, ask other people, have you had experience with these people or this person? What's your experience? Because a lot of times people do things because things are being hyped, and and in the end, it's not as they had expected. So surgical management of endometriosis will end there. I've spoken that there is no known prevention as at this day. Researches are ongoing, and hopefully there will be something better for endometriosis in the near future in terms of early diagnosis, management that is not going to stand on the way of pregnancy. And so, yes, let me quickly talk on, when it comes to fertility. So if you want to start quickly, yes, you can start with the simplest ovulation induction and timed intercourse. If that doesn't work, most of this treatment, virtually every fertility treatment, is not expected to be done once. People come in and say, okay, we want to do ovulation induction, then they do one cycle, and then they're saying, no, we cannot, this didn't work. They are very disappointed, in spite of counseling that when you do ovulation induction, the maximum chance of conception in that cycle is about 20%. So if you accumulate it, you know that, okay, you should do at least minimum of 3, between 3 and 6 cycles of back-to-back ovulation induction if it is done properly and it is confirmed that you actually ovulated in the cycle. Because the other thing is, like I said, we have a lot of doctors now. People buy this medication over the counter, they swallow them, they are not being monitored by ultrasound. So how do you know that the dose you've taken is even okay? How do you know that you actually ovulated? How do you know the number of follicles that the medication has been able to generate? So when you want to do proper ovulation induction, you need to be monitored with ultrasound. It will help us know that, yes, the dose we have given, which is usually a best guess dose in the beginning when you start the treatment, is actually optimal for you, because we have seen that, yes, you have 1 or 2 follicles as a result of the medication. We are able to monitor and advise on, okay, these follicles are ripe now, and then so in a few days you should be ovulating, advise you on when to have intercourse and have it more abundantly. So that is it for ovulation induction. If you do that, if you think you don't have much time, then you can go on to IUI. IUI is like an elder brother to ovulation induction. There is a wide space between IUI and IVF, because we also see that a lot of people feel that IUI 3-letter, IVF 3-letter, so they are side by side. But IUI is closer to ovulation induction because similar to ovulation, you take your tablet or the injection, as the case may be, your ovaries are monitored and the follicles are tracked, what we call follicle tracking scan. And then when they are ripe and you're ovulating, the semen of your husband or partner is treated and injected into the uterus. What that does, it has been able to have shortened the distance that the sperms would have to travel to get to the eggs. You have also been able to cross the barrier, because if some of the sperm are lazy and you deposit them in the vagina, they're just going to say, please, I want to sleep here. I don't want to go anywhere, so they stay there. So you have helped them to cross the barrier of the cervix, and so it shortened the distance, and it may improve your chance of conception a bit over when you have sexual intercourse, especially in people who may have marginal low sperm count or maybe some cervical factor. So if that doesn't work, and again, IUI, you may need to also set aside that you're going to try it back to back for like 2 to 3 cycles before you give up on it. Then you can do IVF. All this fertility treatment, you can choose, mix and match. You can decide to start from IVF. You don't have to start like you're climbing a ladder from this one. Depending on your condition and what you have discussed with your fertility doctor, you'll be able to know which of the treatment is best for you. So you can, IVF is also an option. And IVF, especially in advanced endometriosis, is quite technical. Where sometimes we are actually starting the treatment by trying to suppress the ovary first. We mentioned earlier that most of the hormonal medication that helps with reducing the progress of endometriosis stands on the way of pregnancy. But in IVF, we have seen that there is benefit in, first of all, suppressing this endometriosis because of the inflammation that it causes. to suppress the endometriosis. So give medication for 3 to 6 months before the IVF proper is done. So these are ways that you can treat infertility in women who have endometriosis. So I would like to stop here and then take some questions. Thank you for listening.
Okay, thank you very much, sir. So we have some questions. The first one is, I used to bleed a lot before now, but I had 2 doses of Zoladex injections and I still bleed from my navel and feel pain on my shoulders. So how do we treat abdominal endometriosis?
All right. Zoladex is a medication that is quite intense in its effect. It's one of the GnRH analogs that we have described as an agonist, and it suppresses. In fact, we used to describe it as being able to cause medical menopause. It suppresses the ovary, and if it is done properly during the period that you are taking it, once the effect starts, you're not likely to menstruate. You are not likely to menstruate. And so if you're not menstruating, then you shouldn't have that bleeding in the umbilicus. But once the effect wears off, Zoladex is an injection that, because of the side effects that it has, it can cause bone weakness, what we call osteoporosis. It can cause very severe menopausal symptoms like severe hot flushes and dry skin. It can cause poor lubrication in the vagina. And especially because of the effect it has on the bone, it's not a medication that you can continue to take forever. So when you stop it, then the symptoms are likely to come back. So if you have such kind of abdominal endometriosis, if medical management has not helped that much, then you may require surgery where these lesions can be followed and ablated. Ablation is like burning off. They can be excised, which is like removing them. So that is that's what you need to do. So if you're still having such symptoms, then you need, like I said, see your doctor again, or see doctors with endometriosis interest, and then they'll be able to guide you. What is important is management with different kind of specialists, but you need somebody who can coordinate this management, so that, okay, if you need to go and see this person, say, okay, go and see this one. So most times you're going to do endometriotic surgery, you need other specialists, multidisciplinary approach, where you need to have a bowel surgeon in case to first of all help to prevent bowel injury, and if there is injury, you'll be able to fix it. You may need a urologist who is going to be helping to prevent urinary tract injuries, and if there is, he would fix it. So these are things that we need to know. It's a very dangerous condition, but it's not cancer. We still say it's benign, and so this is what if the medical, that's why we categorize the treatment from expectant, do nothing, to medical, and when medical fail, then you go to surgical. Most times you can also have mixed, where you are combining the medical and the surgical treatment.
Okay, thank you, sir. Someone else said, I have been diagnosed with endometriosis after therapeutic laparotomy 4 years ago. Although I no longer have painful periods, but I'm still not able to conceive.
Yeah, so again, you need to see a fertility specialist so that you can undergo the evaluation. We need to know your age. Is this something to do? When we say therapeutic laparotomy, we don't know exactly what they did. Is it therapeutic because they have removed your ovaries so that you no longer have these symptoms, or they took a chunk of your ovaries out? Is it therapeutic because they have removed the scarification? So we need to, therapeutic is a very vague description saying the surgery was done for the purpose of treatment as against a diagnostic surgery which was made for the purpose of making a diagnosis. So it's not all encompassing. We don't know what has happened. Sometimes even the surgery can worsen the patient's condition if it is not properly done, and there is a lot of scarification arising as a result of the surgery. And that is why you need to choose your provider properly, so that you're not solving one problem and creating a bigger problem. But if you have fertility concern, just see your fertility doctor, and then he would evaluate, are your tubes still open after the surgery? Are the ovaries okay? There are tests to check all this. And then you can even have ultrasound and MRI to say, okay, this endometriosis that they have treated, have they removed all the lesions? Like we said, it's a progressive condition, and at this time, it doesn't really have a cure. So most likely you may have had an extensive maybe treatment. So it's good to reassess your reproductive systems to know whether they are in good condition.
Okay. With menopause, do the symptoms of endometriosis disappear?
It depends on the stage of the endometriosis before you go into menopause. If you have mild endometriosis, moderate endometriosis, which are basically in the peritoneal cavity, because there is no more estrogen. That is what Zoladex was doing to create medical menopause. So if you go into natural menopause, most of the symptoms would wear off over time. But if you have severe endometriosis where there has been a lot of scarring, the damage is already there. That is why when we started, we said, okay, we usually start from cyclical pain to chronic pelvic pain. So when you start having that chronic pelvic pain, which is usually because of scarring, then your symptoms are not all likely to just disappear with menopause. There may be some reduction, quite okay, but it may not disappear completely.
Okay. Does constantly having abdominal pain throughout the year suggest endometriosis?
Yes, chronic pelvic pain. Pelvis is is the lower part of the abdomen. If you have chronic pelvic pain, you would need to be evaluated for endometriosis, especially if you are in the reproductive age group. So when I hear abdomen, I don't know which part of the abdomen, but chronic pelvic pain precisely, is what we're talking about. And if all these things you need to be evaluated, we can't just on the screen say, yes, everybody who has chronic abdominal pain has endometriosis. It may or may not be. And so evaluation is key. Just ensure that, okay, you're seeing somebody who would put all this into perspective in the course of the evaluation. If you don't order the right test, then you will not be helping the person.
Can endometriosis cause constipation?
Yes, endometriosis can cause constipation if there is scarring of the bowel. So if there is scarring of the bowel, endometriosis can cause constipation. It can cause blood in. That's what we call. So you're going to be passing stool with difficulty, defecating with difficulty. That's what we call dyschezia medically. And sometimes you can have hematochezia, which is like blood in the stool as well. But again, I make emphasis that when you hear this thing, don't just go and make self-diagnosis. It's okay, yes, I have chronic constipation. It means Dr. Fache said I have endometriosis. Please just go and get evaluated so that we know exactly what your condition is. And the essence of this presentation is especially directed to those who have this chronic pelvic pain, severe menstrual period, and they are being told to bear it. Don't even let people know you're menstruating. Their symptoms are dismissed by their doctors. To try and go for proper evaluation. If you have a doctor that is dismissing your symptom, please look for another doctor who can check you properly to be sure that you don't have, and if you do, advise you on what you need to do.
Okay. Is migraine and backache also a symptom of endometriosis?
Not common features of endometriosis. You can have endometriosis rarely in the central nervous system, but those are not migraine and what do they call it again? Migraine
And backache.
and backache. Backache, especially if it's lower backache around the pelvis, yes, can be related to endometriosis, but we will not choose migraine as a common symptom of endometriosis.
Are there lifestyle changes that might help?
Like we said, we do not know the cause. There is no particular association in terms of somebody who is slim and fat, but we generally, most conditions, we advise lifetime modification because they have other health benefits. For instance, when we're talking about fertility, for instance, somebody who is obese can have obesity can have adverse effect on infertility. So if you have this obesity, you have endometriosis, then your own infertility may be more worse compared to somebody who is of normal weight and has endometriosis of the same level of severity. So lifestyle modification, keeping healthy, have optimal weight, avoid alcohol as much as possible, do not smoke, and all those things, exercising, yes, they help improve your quality of life.
Is endometriosis inherited?
There are familial tendencies. There's a difference between inheritance that may have to do with genetics and familial tendency, meaning that, oh, if my mother has it, my risk is higher. So there may be some genetic predisposition, but it's not established that certain maybe gene, like you have sickle cell disease, for instance, or Down syndrome. That's not associated. That is not established as such, but there is familial predisposition.
Can someone with endometriosis still get pregnant?
Yes, I said that early in my conversation that it's not, that's where the expectant management come in. That there are times where you could have a diagnosis of your endometriosis and you're told that, oh, this is mild early stage endometriosis, and so you don't need to do anything. So it means that there are people who have endometriosis and can, still conceive. So let us take it that it is not everyone with endometriosis that has infertility. I made that, I clarified that in the beginning. So depending on the stage of endometriosis, the severity and your circumstance, you can still get pregnant without medical help with endometriosis.
When a woman gives birth, does endometriosis stop?
No, it doesn't. We have said it's progressive. If it does, then we'll encourage everybody to go and get pregnant by all means, so that when you give birth, your endometriosis would go away. So we have also emphasized that at this time there is no cure, and so giving birth does not stop your endometriosis. It can delay its progression, but it doesn't stop endometriosis. It's just like asking that if somebody who gives birth will not be seeing period anymore. So if you have a disease that the tissues are behaving like the lining of your womb, as long as you menstruate, then it's likely that your endometriosis will be progressive.
Can endometriosis affect your partner?
Is it by way of sexual transmission? Your endometriosis can affect your partner mentally and emotionally. It cannot be transmitted to your partner. So if that question is asking, yes, if I have a wife that 1 week of every month you have to go and stay in the hospital, it would affect you, because sometimes we feel the women's pain more. Your partner may be feeling your pain, like when you see women in labor, you see some of their husbands crying. Some of them join for cesarean, and once they see the blood, they are beginning to feel like they're going to collapse. So if your partner mentally, yes, it's going to affect your partner. It can, of course, affect your marriage because it can create marital discord for men who don't understand. And this is not just, it has nothing to do with profession. I've seen a doctor who says, after diagnosing the wife of severe endometriosis and giving them option of how to do IVF and the rest of it, okay, why don't I just go and marry another wife? And that is how insensitive some people can be. But it also tells you the extent to which endometriosis can affect your home, meaning you and your partner, even the extended family, your in-laws, your direct parents. So a lot of people can be caught up in the web of this endometriosis. She's in the hospital again. She's, okay. So that's the way it can affect your partner, but it's not like, okay, it's been transmitted sexually.
Okay. Can endometriosis cause navel pain and hardened navel?
If you have umbilical endometriosis, that's in the navel. Sometimes you see that some women, when they are menstruating, they are also bleeding from the navel. So if you have a hardened navel, like there is a nodule there, and you have some of these other symptoms, it may be worthwhile getting evaluated to find out what is causing the hardness. So again, it does not mean that some people have hernia into their navel if you have obstructed hernia or something like there's feces in the hernia, it can cause hardness. So we are not saying that anybody who has hardened navel has endometriosis, but it could be one of the differential diagnosis, something that your doctor would have to be able to check and say, yes, it is, no, it is not. Okay.
Does IUI help in conceiving quickly?
If you have fertility concern, yes, IUI may be one of the fertility options that you can benefit from. But we do not encourage people who do not have fertility concern to go and do IUI so that they can conceive quickly, because you may not have benefit from the IUI in terms of time to conception. So there must be a background predisposition to infertility, like we're saying. If you've been diagnosed of endometriosis and you know that, okay, it's progressive, and so the longer I wait, the worse my disease can get, then you can decide to start fertility treatment. You can decide to have IUI to help you conceive quickly.
Okay, so the last question for now is there any major cause of severe ovulation pain for someone in her late 30s?
If you have severe ovulation pain, it could be due to scarring. Some people can just have mid-cycle pain, what we pronounce as Mittelschmerz. You can try to pronounce it. It's a mid-cycle ovulation pain, and some people have it. They don't necessarily have endometriosis. But yes, if the pain is severe, maybe as to warrant taking some analgesics, then you may need to get it checked whether there is some scarring around your ovary that is causing the pain.
That's okay.
All right, so I'm told that's the last question, and we've done this for about an hour and 5 minutes. We would implore that this will be posted, so you can kindly follow us on all our social media, subscribe to our YouTube channel, so you can get to watch some of these videos, especially for those of you who joined late. Apologies to our Muslim brothers and sisters. We know that this is a time they are breaking their fast, and so some of them may not have been able to stay till the end or to even join at all. So this is going to be on some of our social media, the Instagram page, the YouTube page as well, so that you can get educated and get aware of endometriosis. If the information is not directly useful to you, to be useful to somebody you know, friend, sister, like that. So thank you for your time. We hope to see you soon for another interesting episode. Thank you.